broadcast is now starting. All attendees are in listen-only mode.
That was Air Supply that you just heard singing one of their favorite songs, and one of my favorite songs too, called Lost in Love. And we're going to hear some good music. Maybe we'll even have some more Air Supply today. This is Dr. Minarsik, and it is Tuesday. It is February 8th, 2022, and it's 9 o'clock in the morning here in the Chicago area. In the last 11 webinars, we had a massive marathon into 11 webinars in the GU system. We're all finished, including GU labs and everything. So I'm really happy. Now we have a shorter topic or block or system, or whatever you want to call it. It's called endocrine, okay? And I Honestly, I know I say this about all of the chapters and everything, but endocrine is my favorite. It didn't used to be my favorite, but once I went into nuclear medicine and I could actually see endocrine physiology with my own eyes, I started to really get interested. So the next 4 webinars, we will be talking about the endocrine system. And the first one, which will be today, which will be on the pituitary and thyroid only. And then Thursday will be all the other so-called endocrine glands, although some of them are not really glands by the classical definition. And then we'll be talking about the most important endocrine gland, which you probably don't even believe is an endocrine gland. It's called the pancreas. We'll be talking about diabetes, okay? And then finally, the 4th webinar, at the end of this 2-week period, we'll have another endocrine lab and show you some of the things we've been talking about under the virtual microscope. So I'm really happy to get started. I will admit something. Often the night before a webinar, I have a nightmare that things aren't going to go right. Something's going to get screwed up. The computer's going to blow up, or I'm not going to remember anything. And I had a nightmare last night. But usually when I have the nightmares, they go pretty well. So let's get going, and hopefully we'll go pretty well. Is there anything else I wanted to say? I usually write a little note here. No, I already told you it's one of my favorite chapters. In fact, maybe it's my all-time favorite. So I guess I should know what I'm talking about, right? So let's drop this guy down and put up the endocrine PowerPoints. And of course, from a pathologist point of view, you probably know this is the pituitary gland, the so-called master gland, although some people might even say the hypothalamus is the master of the pituitary. So the blue cells are the basophils, the redder cells are the acetophils. They secrete different kinds of hormones. This one doesn't have a glandular pattern at all. It's the neurohypophysis, or posterior lobe. This might be the main endocrine gland that people think of usually as the thyroid gland, having both follicles surrounded by follicular cells, as some cells between the follicles called parafollicular cells. These guys secrete thyroid hormone, and these guys secrete calcitonin. Here we are in the parathyroid. Most of these cells are chief cells. The red cells are the oxyphil cells. And of course, another extremely important part of our body, the adrenal gland. All of this stuff is cortex, but where you see these wide vascular spaces, that's the medulla. Okay, quick review. Let's talk about what we're going to talk about. These are pretty much all of these classical endocrine glands I just rattled off. However, you should probably know that there is a much broader definition of endocrine rather than the classical endocrine glands like we see here. Actually, endocrine is a secretion from one cell that travels through the blood and goes to another cell. That's a classical definition. So besides these, 5 or 6 endocrine glands here, we probably have at least 100 that do that function but are not called endocrine glands. Okay, now in the classical way we've always discussed diseases or systems, or what we would call blocks, we generally talked about the degenerative diseases. Now in the case of the endocrine system, a lot of these glands involute or atrophy, or you could say degenerate with age. The thyroid is probably the most notorious example. Excuse me. Because if I told you that the weight of the thyroid is probably twice of what you saw when you were cutting up dead bodies of elderly people, then you know it's normal for most of these glands to generally get smaller and degenerate, or involute is the word that we use with endocrine glands. We'll talk about the inflammatory diseases. We'll talk about the neoplasms. Some of them are benign, some of them are malignant, and most of the so-called tumors or nodules of the thyroid are not really true neoplasms at all. They're just regular nodules. And I bet you, if you remember dissecting last year in anatomy lab your thyroid, you probably remember seeing that most of the thyroids were not really smooth. They had kind of a nodular configuration. Some of these might even be palpated. Okay, that's the classical algorithm, folks. We're not going to use it. We're going to use a better, more tailor-made algorithm for all these endocrine glands. We could divide them into non-neoplastic, in which there is either hyperfunction, overactive, excessive hormones, or hypofunction, underactive or inadequate hormones. And then we have the neoplastic ones. They could be functional or they could be non-functional. Neoplasms could be benign or they could be malignant. However, one of the most important overall rules of entire pathology is that if we have tissue that is malignant, it's probably not going to function in a hyper manner because it is de-differentiated. So functional endocrine true malignancies are pretty rare, and I just explained to you the reason why. Okay, this is the feedback system, the classical feedback systems for general endocrine function. We all know that even though the pituitary gland, okay, anterior pituitary, posterior, even though the anterior pituitary gland secretes the hormones that more or less control the thyroid, the adrenal and so forth as targets, it's not the pituitary itself that is the source of the stimulus. It's actually the hypothalamus. The hypothalamus generally releases releasing factors to the anterior pituitary, or even more spectacular, it actually makes the hormones and sends them down axons to the posterior pituitary. How do you like that? Then the pituitary gland, we'll say anterior pituitary now, sends stimulating hormones to the endocrine gland to release their hormone, the end hormone, to the end organs. And then the amount of hormone then feeds back to both the anterior pituitary and or the hypothalamus to slow the process down. So we just talked about the negative feedback system. Anything that stimulates a tissue to produce something is positive feedback. It's like when you say, hey, Minarsik, that lecture was great. Well, that's positive feedback. And if you say, hey, man, you don't know what you're talking about, you suck. Well, that's negative feedback. So to make the story even more interesting, there is no doubt that the hypothalamus is not the mother of all endocrine. It actually receives stimuli from both the cortex, okay? That's consciousness. Things like anxiety can ultimately filter down through the subcortex of the hypothalamus to release the releasing factors, to release the stimulating hormones, to release the various hormones, okay? So here, let me give you the classical example of thyroid now. You have your hypothalamus. If you want to call it the master endocrine gland, you can. It's not really an endocrine gland per se, but it secretes the releasing factors. And in some cases, it even makes the hormones, okay, which go to the posterior pituitary. Because the posterior pituitary does not make hormones by itself. It just receives them from axons in the hypothalamus. Then the anterior pituitary has a variety of hormones that affect the gonads, the adrenal glands, the thyroid glands, and the stimulating hormones, in this case TSH, stimulates the thyroid gland. Then the thyroid gland, in a positive feedback way, secretes T4 and T3. T3 is actually more metabolically active than T4, but they have similar properties. Then the T4 feeds back to both the anterior pituitary as well as the hypothalamus to slow down the releasing factors or to slow down the TSH. So that's this complex, ingenious scheme for positive and negative feedback. I mentioned here that the anterior pituitary is like Wi-Fi. Why? Because these hormones travel, okay, in the blood without being connected directly by wires to the anterior pituitary. But the posterior pituitary makes the actual hormones, oxytocin and vasopressin, which actually travel down the axons and are released by the terminal portions of the axons in the posterior pituitary. So the posterior pituitary is not really glandular tissue, and it doesn't make by itself hormones. It just receives them from the hypothalamus. Isn't that something? Okay, here we go. Perhaps a little bit more graphically. You might remember that the hypothalamus has a variety of nuclei. These are the hypothalamic nuclei. They have a bunch of names, and then ultimately these nuclei, I could even show you a picture of some of the names of these crazy things, like the dorsomedial, the posterior, the mammillary body, perhaps is not part of the hypothalamus itself, but it's in very close proximity. The suprachiasmatic, you might think right be above the optic chiasm. The medial preoptic, the anterior, they're usually defined by where they are, anterior, posterior, dorsal. Ultimately, these nuclei have an intimate relationship with the anterior and posterior lobe because some of them secrete the releasing factors to travel by blood to the anterior lobe, or they secrete other hormones that are not distributed through the blood but through axons into the posterior pituitary. So anyway, that's the general scheme. And then we have the stalk. Embryologically, this may have been called the infundibulum. And we have the both anterior lobe, which is real glands. We have the posterior lobe, is actually neural tissue. Okay, the cells which compose the posterior lobes are actually glial cells, okay? They're not classical glandular cells. Two kinds of hormones, if you want to think simplistically. Most common type is the polypeptide hormones. You're usually, 5, 7, 12, 30 peptides, okay? And I'm going to show you the polypeptide hormones work as a general scheme by this complex scheme called the second messenger. In other words, the hormone doesn't produce the effect directly. It goes through a little cascade to bind to another cell, usually at the membrane. The G protein within the cell is activated. The activated results in the production of a second messenger, like nitrous oxide or CO or a whole bunch of other things, but look, maybe there's 5 or 6 common ones. And then finally, the second messenger actually activates the intercellular process. Okay, well, if that sounds pretty complicated, I have good news for you. The steroid hormones, which is the second type of hormone, works directly on the cell. It doesn't have this complex second messenger. The steroid hormones, cholesterol based, go directly to the nucleus and do their thing. And if you would imagine that now a hormone is going directly to the nucleus, it's probably going to have something to do with growth, isn't it? Because that's where it would start. Okay, once again, this is a real pituitary now. All these red cells are the acetophils. You can see some kind of more bluer cells, which are not as popular as the red cells. Those are the basophils. You see a so-called intermediate lobe, which to this very day, nobody knows exactly what it does. But it often has these little follicles like you see here, very much looking like the thyroid follicles. And then you have an area that looks like brain. Why? Because it is brain, okay? These are not glands at all. These are not follicles. They are glial cells and axons, okay? And the axons release the hormones that were made all the way up here in the hypothalamus. And there's only two principal ones in the posterior lobe. There's the vasopressin and oxytocin. There's a variety more. There's about 5 or 6 that are from the anterior lobe. And here's the anterior lobe. I think you could see why this cell might be called an acetophil, because it's more acid in the dye and therefore it turns red, like an eosinophil in a way, but they're not called eosinophils, they're called acetophils. And then we have the ones that are bluer, like up here, and those are called the basophils. And the acetophils generally release hormones involved in growth, like growth hormone or prolactin, whereas the basophils release hormones that generally stimulate other endocrine glands, like the thyroid, like the adrenal, for example. And here's the entire pituitary gland up here. If you've seen it, you probably have not seen your pituitary gland on your dissection of the cadaver. Even if you did a very, very careful removal of the brain, this little stalk here is completely separate from the brain, and it's impossible to remove the brain with the pituitary, because you have to chip away through the clivus, because this thing sits inside of what they call the dorsum sellae of the clivus, and you actually have to chip away into the anterior and posterior clinoid processes to remove it. And everybody always describes the entire pituitary as being pea-sized. So if you remember how big a pea is, not a big pea, but a regular pea, that's about the size of the pituitary gland. About 90 or 80 or 90% of which is anterior lobe, originating from Rathke's pouch, embryologically, as well as the posterior lobe, originating from the so-called infundibulum, okay? So here we go, and let's talk about the cells again. In the anterior pituitary, they're chiefly polypeptides. They're working by second messenger. The acetophils, those red cells, secrete growth hormone, okay, and prolactin, okay. The basophils secrete hormones which stimulate other endocrine glands, like the thyroid with TSH, or the adrenal cortex, ACTH, or the gonads, ovaries or testes, with luteinizing hormone, FSH. You know, the important hormones that we've seen involving the menstrual cycle. And in addition, luteinizing hormone in the male stimulates the interstitial cells. So in the male, it's called interstitial cell stimulating hormone, ICSH. But that's the general function now of the polypeptide hormones from the acetophils and basophils. I'm going to mention this again, but think about it. If you have a tumor of the anterior pituitary, in which the cells all look red, it could very easily be producing an excessive amount of either growth hormone, produce a giant, okay, or prolactin, perhaps produce some type of early lactation without pregnancy. And it's not true lactation, it's basically a pre-lactation. If you have a tumor of the basophils, it might result in an overproduction of thyroid hormone, okay, through excessive TSH, or an overproduction of corticosteroids due to increased TSH. And that's also true for the sex hormones, the luteinizing hormone, okay, stimulating the corpus luteum, and the follicle stimulating hormone, stimulating the ovarian follicles. And remember, LH also stimulates the cells in the testis, which produce testosterone, which are the interstitial cells. What is this? You're probably thinking, oh my God, how come he's showing this stupid brain picture? We're supposed to be talking about endocrine glands. This is the posterior lobe. The posterior lobe looks like brain. These look like glial cells. Why? Because they are glial cells. Oh, they're called pituocytes, but they're modified glial cells. So when we told you there's about 3 or 4 types of glial cells, there's actually a fifth, another one called the pituocytes. Here's some nice blood vessels. It's very rich. And all the rest of these kind of feathery things are axons. Now I want to show you something really cool. Here's also a higher picture of the posterior lobe, or neurohypophysis. And you can see there's a bunch of pituocytes, or glial cells. There's no glands per se. But you see that little red thing? It looks like it's even bigger than most of the nuclei. That's actually a terminal axon, okay, of the posterior pituitary. And it's so bloated, it's so big, it's actually bigger than most of the cells that support it, okay? And this is called a herring body, and these are the terminal axons which actually secrete the hormones of the pituitary, notably oxytocin, which contracts uterine smooth muscle, and vasopressin, which does a whole bunch of things. Okay, here we go again. Where are we? Let's put that back down first. So these are the hormones of the posterior pituitary now. Oxytocin contracts uterine smooth muscle. Please don't ask me what it does in the male, because really, I don't know. I should have looked it up last night, but it might not do anything, okay? Now, vasopressin is also called anti-diuretic hormone. Why? Because it saves water. It prevents or retards or diuresis, okay? So, by virtue of it retaining water, it retains a blood volume. And by virtue of retaining a blood volume, which also retains sodium, because where the water goes, the sodium goes, it also has a tremendous effect on blood pressure, because the greater the blood volume, the greater the blood pressure, okay? So it saves or increases or spares water in the body. And of course, once again, whenever I say water, you have to think of sodium, because where the sodium goes, the water goes. Now, vasopressin has a whole bunch of other things that it does, okay? It's a vasoconstrictor in itself. It's involved in gluconeogenesis, okay? The manufacturing of carbohydrates from non-carbohydrates. It's involved with platelet aggregation and coagulation. It's involved in the release of factor VIII and von Willebrand's factor in coagulation. And of course, if it retains water, or if it's in excess, perhaps a tumor making it, or an overproduction, then it would have an effect of having edema of the brain, which means it could be severe edema even. And here are your 9 amino acid polypeptides here for oxytocin. And believe it or not, probably, I don't know if it's a coincidence, but another 9 amino acid structure of vasopressin, or ADH, as well. Now, what could go wrong with the pituitary? Well, you could have a tumor. Okay, if you have a tumor, that little P inside of the dorsum sellae can get bigger. It could even grow out of the dorsum sellae, okay, and affect the hypothalamus. You could have an adenoma producing excessive hormones, and they're so-called resulting clinical syndromes. It could hypofunction due to tumor, due to radiation, other things as well. You could hemorrhage into it. You know, sometimes postpartum, the pituitary shuts off. It's called Sheehan syndrome, but we'll talk about that later. Or you could have a variety of posterior pituitary syndromes, in which if you have damage to the posterior pituitary, you're not going to be anti-diuresing anymore, are you? As a matter of fact, you're going to be diuresing, because if you damage something that's an antidiuretic, it's gonna have a diuretic effect. So they call it diabetes insipidus. And you could even get that from a head injury. If you're in a whiplash injury, let's say, and you actually shear or cut or destroy the stalk of the pituitary, you no longer have that pipeline between the hypothalamus and the posterior pituitary. Or you could have a suprasellar tumor or even a hypothalamic tumor. Why? Hypothalamus is part of the brain. Could that part get a tumor as well? Yes, it can. So it's all of these things are possible. This is like the broad spectrum of pituitary pathology. And now we're going to go into some of the particulars. If you have a tumor with hyperfunction of the acetophils, which are labeled A, then you're either going to have excessive growth or lactation or inappropriate lactation, okay? The physiologic process of lactation is more than just prolactin, which is made from the acetophil. It involves a variety of hormones, okay, including thyroid hormone as well. So if you have hypergrowth of the acetophils by virtue of tumor, then you could have giantism, another type of giantism called acromegaly, or lactation, and this is called galactorrhea because it's not true lactation because there's no pregnancy involved. You could have hyperfunction of the thyroid gland, producing hyperthyroid effects. You could have hyperfunction of the adrenal gland, producing the effects of hyperadrenal cortexism, okay, also called Cushing's syndrome. You could have hypo effect where growth is retarded. You could have a hypo effect where the thyroid function is retarded, hypothyroidism, or you could have hypo effect where the adrenal cortex is also hypo-functioning, not enough, okay? And this has various clinical expressions too. Now, it's pretty obvious that if you have hypergrowth of any part of the pituitary, and that part is within the dorsum sellae, but it enlarges. Rather than being a pea, it could be a baseball, okay? But generally speaking, once that tumor arises superiorly from the dorsum sellae, first thing it's gonna do is screw up the optic chiasm, because the optic chiasm lives right above it. Okay, it can also affect the brain as well. Here, this is something you might remember in great detail. Here's the base of the brain, here's the pons, here's the brain stem, here's the cerebellum. But look, here are the optic nerves, and they desiccate 50% of the fibers from the optic nerves desiccate or cross over to the other side, and 50% stay on the same side. And that is right exactly in the area of the stalk of the pituitary. So if you can imagine a tumor arising from here, the first thing it's probably going to screw up is the desiccation, and you're going to have some visual field problems, okay? And of course, if it gets very, very large, it can screw up a lot of other things as well. But here we go. What if there was an acetophil adenoma of the anterior pituitary? Not any pituitary tumor that grows, but specifically an acetophil adenoma. Well, acetophils make prolactin, and this woman can have galactorrhea. Okay, that's not true milk, but it's very close to it. And a non-pregnant woman that presents to your office with galactorrhea will probably immediately get a brain scan, MRI scan, to see if there's a tumor of the pituitary. And if there is, most likely it's derived from the acetophils which make prolactin. What if a guy walks into your office like this? I don't know if you're a wrestling fan, but this is Andre the Giant, okay? He's a true giant. He has giantism. He had a tumor which produces excessive somatotropin, also called growth hormone. Now, if this excessive amount of growth hormone occurred before his epiphyseal closure, when he's like 18 or a late teenager, let's say, then the whole body is going to be big, okay? This is the effect of excessive growth hormone. It's called gigantism. But what if the tumor occurs after the epiphyseals close? Well, there's no more bones that could grow to make him tall or big, but rather than the bones growing in length, because the epiphyses are closed, they grow laterally and they have these little clubs. So they have prominent jaws, they have very prominent knuckles or fingers, and they're not going to be nearly as big as Andre the Giant because they can't really grow anymore. And probably, I would say, I don't know if you'll ever get this on an exam or something, but whenever they show a picture of an acromegalic, they always show a guy like this who has a very, very prominent jaw and forehead because of overgrowth of bone after the closure of the epiphyses, and especially the hands. And they might even show you a hand x-ray as well, which is over here. Do you see these little lateral projections of the pre-epiphyseal bone? That's because the bone wants to grow, but the epiphyses is already closed. Okay. What if you have somebody coming into your office and they have a nice little hump of fat right at the nape of their neck? They call it a buffalo hump, and you could say it's fat. Or we'll say they have a nice big smile. This is called a moon facies. Moon facies means there's excessive fatty deposition in the face to make the person's face look like a little moon, okay, a round face. There's her brother that doesn't have a moon face. Or let's say, it could even be a man that has these lines in his lower abdomen, and he's probably also obese possibly. And they may be diabetic as well, and they may have ulcers as well. Well, these are called striae. And if you've ever seen a woman after she's delivered a baby, striae are very, very common. And they eventually go away. Okay, but let's say a man comes in, or he's not pregnant, or she's not pregnant, and you get these little linear lines in the lower abdomen. Those are called striae. These are classical features of excessive cortisol. Okay, so if you have a tumor of the basophils of the pituitary producing excessive ACTH with excessive stimulation of the adrenal cortex, and therefore excessive production of cortisol from a positive feedback standpoint, you might get people that look like this. Okay, what is this? Well, when MRI first came around, and believe me, I'm old enough to know what it was like before MRI. But when I started reading MRI scans, and you would take these nice sagittal or midline sagittal sections of the brain, you could see the nice cerebellum, you could see the pons, you could see the cortices, the ventricles, but you can also see this big bone, okay, called the clivus. It's part of the sphenoid bone. And at the superior portion of the clivus, there's this little indentation. It looked like a saddle. In fact, it looked like a saddle that the Turks used to use when the Turkish guys used to go on their horses. So it's called the sella turcica. And the sella turcica is a space in the superior portion of the clivus. And in that space, you see a nice little soft tissue structure. It's not bone, like in the clivus. It's not fat, okay, like in the scalp. But it actually has the same signals as the brain, okay? That's the pituitary gland. And then the so-called stalk of the pituitary, or infundibulum, connects it to the hypothalamus. So you could see it's impossible to remove the brain with the pituitary. Once you remove the brain, you chip away at those clinoid processes, and you could take out that little P structure. And if you notice that the back part of the P, or posterior, is not quite as juicy as most of the 90% of the anterior part, you're actually looking at the posterior and anterior lobe of the pituitary. This is completely normal, okay? But what would happen if this guy presented with some type of hyper hormonal effect of the thyroid, of the breast, of the growth hormone, of the adrenal cortex? Maybe he's got a tumor that's producing adrenal excessive amounts of stimulating hormones, and look how it has grown out of the cella. That doesn't mean it's malignant. It doesn't mean it invaded the bone. It means it just grew out. And now you have a tumor that's pretty big. So your pea-size pituitary now looks like it's about the size of a big grape, okay? And here is the tumor now. You can see this is, I've never seen one this big, but this is one that is almost as big as one of the hemispheres of the brain. So this is a classical MRI and pathology lab slice. This is a coronal slice. This is a midline sagittal slice of a pituitary tumor escaping the dorsum cellae, sella turcica, I'm sorry. What's this? Well, this is what you would see if you were standing on a big building. Maybe that's the Eiffel Tower, I don't know. And you could see laterally, your actual visual range is almost 180 degrees. So you could see a perfectly wide field. But let's say you can't see your lateral fields, okay? Or what they call the temporal visional field. So you have an hemianopsia, or hemianopia, some people call it, and you can't see laterally. And it's on both sides. So it's a bitemporal hemianopia. What would cause something like that? Well, if these are your optic nerves, and they desiccate right there at the optic chiasm, and then they become the optic tracts, 50% of these fibers go here, and 50% cross over. That's desiccation. And the same thing on this side. And then they go to the lateral geniculate bodies, and then ultimately they get filtered out through the occipital visual cortex. But right here where they desiccate is the optic chiasm. And the optic chiasm overlies the pituitary. So if you have destructive to the optic chiasm, you're not going to see your visual fields. Now, my son is a ophthalmologist. As a matter of fact, he's a very famous ophthalmologist, certainly 10 times more famous than me. But anyway, that's another story. He actually told me that you never get perfect. I mean, yeah, you could have something where the visual fields are blocked out laterally or temporally, but it's usually not perfectly equal with each other. Usually it's one side more than the other. Why is that? Because tumors are not under any rules to grow symmetrically. That's why. A tumor can actually go off more to the left or go off more to the right. And if you remember this picture over here, it went off more to this side, okay? So anyway, but generally speaking, bitemporal hemianopsia, there's a way to measure your lateral visual fields. You learn it in physical diagnosis. And if they can't see laterally, they might have a pituitary tumor screwing up the optic chiasm. And that's why. Now, of course, if they had a lesion of the optic nerve, they would just not see on one eye. If they had a lesion only at the optic tract, which is below the chiasm, they would have visual field defects, but one of them would be nasal and the other one would be temporal. Okay. So let's get into the physiology. We talked about tumors, we talked about cells. But what if, generically speaking, the pituitary was not functioning? Well, I really do believe that all of these are very, very logical reasons, okay? There's a couple I might have to explain. But if you got a tumor there, it's screwing up your normal pituitary, okay? The tumor could even be functional, okay? But it could still suppress the function of the rest of the pituitary. You could have a metastasis there. There's no law saying you can't have a metastasis to the pituitary. Hey, there's no law saying you can't have a primary tumor of the brain or of the portion of the brain above the pituitary, okay, that involves the pituitary, okay? A brain tumor, a non-pituitary brain tumor, okay? Maybe if patient has had pituitary surgery, well, that would be a good reason for perhaps relative or perhaps severe lack of pituitary hormone function of various kinds. Patient may have had brain radiation. You think radiation zaps normal cells, normal function? Of course it does. There's a term that is used commonly, and it's called apoplexy. Now, it sounds like a crazy word, but it's not really a specific disease. It means sudden hemorrhage into the pituitary for any reason. You know, maybe there's been an aneurysm or a stroke or a hemorrhagic CVA, okay? So sudden hemorrhage within the pituitary, generically speaking, whatever the cause is, might produce lack of function or hypopituitarism called apoplexy. Sometimes women that have given birth in their postpartum may have had excessive bleeding, okay? And that may have resulted in ischemic necrosis of the pituitary. And a classical example would that be a woman who gives birth, but then she can't lactate after the baby is born, okay? That's called Sheehan syndrome. And if you also remember, the pituitary or anterior lobe derives from part of the foregut called Rathke's cleft. In its embryologic development, like we've seen in many other parts of the body, it could have cysts, and those cysts could compress or interfere with pituitary function. I hope so far everything has been pretty logical, okay? There's also a genetic defect. If you would guess that a gene that's involved in proper pituitary function might be called the PIT1 gene. Gee, I wonder why it's called PIT. Then maybe a genetic defect involving mutations of the PIT1 gene would also result in hypopituitarism. I've been to several grand rounds also where they talk about the empty sella syndrome. Okay, now it's not a disease per se, but it's generally kind of a mysterious disorder, but it's basically a situation where you look into the pituitary with MRI and there's no gland over there. There's no pituitary gland. Well, why wouldn't there be no pituitary gland? Could it be a genetic disorder? Could it be an embryologic disorder? Well, in most cases of empty sella syndrome, it's not because of the pituitary, but it's because of the sella. If the sella turcica is enlarged, okay, maybe that has interfered with the proper positioning of the pituitary gland. Okay. Let's talk about the posterior pituitary per se now. We said that the lack of vasopressin, which is made by the hypothalamus and released by the posterior pituitary, the lack of vasopressin due to any pathologic or pathophysiologic is called diabetes insipidus. Well, like diabetes, it's excessive diuresis. And why is there excessive diuresis? Because the anti-diuresis function has been interfered with. Another, even more exotic syndrome of the posterior pituitary is called not due to necessarily a lack of vasopressin or ADH, but it's inappropriate antidiuretic hormone, inappropriate vasopressin. Well, why would you have inappropriate? Well, remember we told you that vasopressin is made in the hypothalamus, travels down the stalk of the pituitary, released by the Herring bodies, the terminal axons. Sometimes that hormone, ADH, is also made by tumors, specifically lung tumors, specifically small cell carcinoma, but even some other conditions of non-tumor lung pathology. So, in diabetes insipidus, you got damage for any reason, including whiplash, okay? Where you're cutting the stalk of the pituitary and a sudden jerk of your head, you have ADH deficiency. Now, if you're no longer antidiuresing, then you have hyperdiuresis, and the more hyperdiuresis they have, the more watery your urine is, so you have a low specific gravity. Now, in an inappropriate ADH, you might have an ADS excess because it's being released inappropriate or not part of its normal physiologic feedback mechanisms. Maybe a tumor is doing it. So now you have excess water. You have cerebral edema. It could result in neurologic symptoms. You might have a small cell carcinoma, which you know is a neuroendocrine carcinoma, and that thing can release ectopic ADH independent from the hypothalamus. You could have posterior pituitary injury, where you're not necessarily having a decrease in ADH, but an excess. That was a little harder to figure out, because I think if your posterior pituitary is injured, you're more likely to produce low ADH. But in some cases, it could just screw up your feedback mechanisms and it'll result in excess of ADH. And there's even some non-neoplastic lung diseases. But if it is a neoplastic lung disease, it's most likely going to be a small cell. Okay, you know what? We've said about everything about the pituitary that we could possibly say. And I think you know what this is now. This is the blood supply of the thyroid. So we spent our entire first hour talking about the so-called master pituitary gland and all the common diseases that could cause it to have a disease. We come back in the second hour after the second half, and we're only going to be talking about one other endocrine gland, and that's the thyroid. So let's drop down the PowerPoint, and let's give you 3 songs, and we'll see you in about 10 minutes.
There's a place called Kokomo. That's where you wanna go to get away from it all. Bodies in the sand, tropical dream melting in your hand. We'll be falling in love to the rhythm of a steel drum band. Down in Kokomo, Jamaica, ooh, I wanna take you to Bermuda, Bahama. Come on, pretty mama, Key Largo, Montego, baby, why don't we go to the Kokomo? You can play it fast and then we'll take it slow. That's where we wanna go. We gotta go Kokomo. Martinique, that Montserrat mystique. We're out to sea, and we'll perfect our chemistry. By and by we'll defy a little bit of gravity. tales of moonlit nights. That dreamy look in your eye, give me a tropical contact high. Way down in Copenhagen, Jamaica, ooh, I wanna take you to Bermuda, Bahama, come on, pretty mama, Key Largo, Montego, baby, why don't we go to the Coconut? Fast and then we'll take it slow. That's where we wanna go. Way down in Coconut. Prince, I wanna catch a glimpse. Everybody knows a little place like Coconut.